8:42 right now, 590 WKZO, and joining me in studio right now is, it's Dr. Itawi.
Good morning.
Dr. Itawi, welcome. You are with Bronson Methodist Hospital. Edward Itawi, a colon and rectal surgeon with Bronson Colon and Rectal Surgery. And we're here to talk about colon cancer. Dr. Itawi, welcome to the program. Glad you're here.
Good morning, Jeremy. Thanks for having me, and thanks for inviting me to your show.
Now, we bring you in here because, we always like to think ahead. And March coming up, not only hopefully the beginning of spring for all of us, but also National Colon Cancer Awareness Month. And with that, I mean, you hear so much about different kinds of cancer, breast cancer and things like that, lung cancer certainly. But how prevalent is colon cancer?
Well, colon cancer incidence is about 40 per 100,000 individuals per year. So to put that in perspective, the prevalence or the lifetime risk of getting this cancer is about 1 in 20 individuals. So for breast cancer, it's about 1 in 9. For colon cancer, it's about 1 in 20. It's actually the third most common cancer after lung and breast, and the prostate in males. This means that the life expectancy of, the life expectancy in the U.S. is about 80 years or so. 1 in 20 individuals will be diagnosed with colon or rectal cancer.
Okay. All right. And now, we say colon cancer. Are there different types, or is it just one that you're constantly dealing with?
Well, by far, the majority, or 90% of colon rectal cancers start in the inner lining of the colon. It is called, we term it adenocarcinoma.
Okay.
We know that the origin of those cancers start in a polyp, or a growth that could be as small as a grain of rice. And over years, the polyp grows, reproduces, and invades and turns into a mass, i.e. we call it cancer. There are other subtypes of colon cancers that are rare and come from other cells. For example, would be something like a lymphoma, which could happen. But the majority, I say by far, is 90% adenocarcinoma.
Now, we talked about those stats a little bit earlier. You said 1 in 20. So for some people listening right now, they'd be sitting here going, well, colon cancer, I mean, is that the kind of thing that I'm at risk for? So who falls into that at-risk category?
Well, simply put, being alive is a risk factor for colon cancer. It can present in people as early as their teens. But the most significant or common risk factor is age. People over 50 are at considered higher risk, and the older you are, the more likely you're going to get this type of cancer. People with family history of colon cancer and people who've had polyps in the past also are at higher risk. People who have inflammatory bowel disease, such as if you've heard something called Crohn's or ulcerative colitis. Also, there's some certain ethnicities. For example, African Americans are at a slightly higher increased risk of colon cancers.
Okay. All right. So when you fall into that risk category, are we talking about early screening then?
Well, yes, there's a few things that, every certain individuals can do. The most important thing to do is you should talk to your primary care provider, your doctor, your nurse practitioner, your PA, and make sure that you have the basic facts. I would say all primary care providers have that information ready for you. You have to start that conversation sometimes. In general, we advise everyone over the age of 50 to get a colonoscopy every 10, sometimes 5 years. For those who do not know what the colonoscopy is, it is a 20-minute procedure where the doctor, first they put you to sleep and they insert a small camera that is connected to a lubricated tube that is the width of a pen through the anus and checks the entire lining of the colon, which is about 4 feet. It is coiled inside your abdomen. And if those polyps are found, they are removed, and hence, if you remove enough polyps, you could prevent a cancer from happening. Most people have no polyps and need this procedure to be repeated just once every 10 years. If there are polyps, they may need to be returning back for this procedure every 3 or 5 years.
Okay. When you do a procedure like that, do you know pretty quickly if you're looking at something, okay, that's colon cancer then, or is it more of a process?
Well, most of the time, actually, we're not looking for colon cancer. We are looking for those polyps. Colon cancer happens down the road. It is a rare thing. So when you get this polyp, we know that if you leave that polyp alone over 2 or 3 years, it is going to turn into cancer. So yes, we remove that polyp. We send it to the pathologist. In a few days, you'll get a call from your doctor, and they will tell you what that polyp looks like.
So the polyp is the starting point. Then.
That's what I'm here for. You need to remove that, and you need to know actually that you don't have that polyp. That's a good thing to know.
Sure.
I don't have those polyps.
Sure. Now, we talk an awful lot about colon cancer and that kind of thing. Are there non-cancerous concerns that you would also treat in a procedure like that?
Well, yes, there's conditions like diverticulitis, hemorrhoids, colitis that sometimes can mimic colon cancers. And at Bronson Colorectal, we provide management for these conditions that at many times are non-surgical. But the message of the day today is going out to those who are over 50 and are uncomfortable with or are too busy or feel it is not necessary to have this colonoscopy. My message to them is please think about it, get screened, and don't wait and talk to your primary care providers.
If you think something like that, you got to make the time for something like this because it could make all the difference from what you're telling me here. So
to me, it's similar to brushing your teeth every day or changing the batteries on your alarm at home. Those are things that are it's an assurance for you, for your future, for your family's future. So you would sit tight and know having that knowledge is to me is very important. Even having the knowledge that you don't have those polyps.
Now, obviously, I heard you say earlier one of the steps is getting in touch with your primary care doctor, whether it's a family doctor or otherwise. Is there any other place that people can get a little more information on things so that maybe we can put their mind at ease or maybe get them to do a little more proactive work on this?
Of course. This is what I caution you. I mean, you can always go on the web, which is the number one source of information for even doctors nowadays. But you have to look at the specific sites. I will go to the American College of Surgery, American College of Colorectal Surgery, the American College of Gastrointestinal Surgery. All you have to do is just Google or whatever you do. You can go on those websites and read the information they have. They have information for the public. Bronson Hospital has information out there for patients who want to be who have any questions, and many of the primary care providers again have brochures on this.
Okay.
Again, it has many times the biggest thing that I notice that people who do not get screened is it comes from them. They say, they think, well, I'm not at risk, or it's a cumbersome procedure, or they don't even think about it. So you have to start with you. And that's about 20-30% of the people who are eligible, and their insurances most of the time, not all the time, sometimes now they're paying for it.
Okay. All right. Well, March National Colon Cancer Awareness Month, and we wanted to make you a little aware of it earlier so you can maybe make those appointments in time for March. Dr. Edward Itawi from Bronson, thanks for coming in today to enlighten us on this.
I appreciate it. I would like to say to all my patients and every patient out there who are treating or getting treatments, surgeries, or chemo radiation for colon cancer from Bronson Hospital and the West Michigan Cancer Center, that I would like to tell them and remind them that it may be 2 feet of snow out there and 0 degrees, but we all know that warm, sunny days are coming. Thank you, Jeremy, and thanks for having me.
All right. Thank you, Dr. Itawi. We continue here at 590 WKZO.